right, good afternoon, everyone, and welcome to today's webinar, which will focus on the Transplant Cost Report. We're joined today by two very knowledgeable professionals in the field, and we look forward to having them share their insights. Now, I would like to take this opportunity to introduce myself as your host for today's program. My name is Deanna Fenton, and I am the Program Manager here at the Alliance. Now, before we go ahead and get started, there are some quick notes and reminders that I'd like to review for those of you who may be new to this platform. Now, upon logging in today, you may have noticed that your audio lines are muted. Please note they will remain muted throughout the course of today's presentation. This will help us ensure the best audio quality for both of our presenters. That said, we do ask that you take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat will be used to pose your questions to our presenters during the Q&A, so if you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation has concluded, we'll go ahead and transition into our Q&A discussion, where our presenters will address as many of your questions as time allows. Now, as an added note, when accessing our webinars, we highly recommend using the Chrome browser to ensure an optimal visual and audio experience. If you're already using Chrome and experience any audio issues, we recommend reconnecting to the webinar using the phone number that was provided in your confirmation email. Should you need any assistance, please feel free to contact a member from the Alliance team or send us a quick note in that chat box. Now, for anyone interested in our upcoming webinars, please note registration is currently open for the next transplant-focused webinar, where we'll discuss frailty and cognitive impairment in kidney transplantation. Be sure to join us for that next week on October 20th at 3 p.m. Eastern. And registration is also open for our first installation of the Brain Death Declaration series, which will highlight clinical and ethical challenges in pediatric brain death. You can mark your calendars for that on November 3rd at 2 p.m. Eastern. For more information on all of our upcoming webinars and to ensure you have the latest information, please visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you're all eligible to claim continuing education credits. For this webinar, we are offering 1 CEP-C credit and 1 nursing contact hour as a result of your participation. Additionally, a certificate of attendance is available for those of you seeking CEs that may not be offered. Prior to receiving your credits and certificates, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder to everyone, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, we are happy to announce that this webinar is sponsored by Paragonix Technologies, a proud corporate partner of the Alliance. Paragonix has a mission to advance standards for organ transport to improve patient outcomes worldwide. The award-winning, first-of-its-kind Paragonix devices provide a sterile, temperature and pressure-controlled environment for organs traveling between operating rooms. Their products are designed to be easy to use in stressful, fast-paced environments where there is no room for mistakes. We thank Paragonix Technologies for their contributions to today's webinar and appreciate their ongoing support. Now, without further ado, I'd like to go ahead and begin today's program by introducing our moderator, the Alliance's very own program consultant, Belinda Jones. Belinda, as you know, I'm very appreciative for having you join us today, and at this point I'll go ahead and turn it over to you to introduce both of our presenters.
Thank you, Deanna. It's my pleasure to introduce our speakers today. The first one will be Alex Aussi, BSN RN MBA. Alex is the Chief Executive Officer of Guthrie & East, the largest transplant consulting firm in the U.S., and he oversees the clinical operations and transplant finance consulting functions of the company. Alex has over 30 years of experience in healthcare, 27 of which have been in organ transplantation. Alex has extensive experience in transplant administration, new transplant and VAD program setup, marketing, managed care relations, contract management, and audit of Medicare acquisition cost centers. Alex has served on various UNOS subcommittees and as chair of the AST Transplant Administrator Community of Practice. Alex is a frequent presenter on relevant transplant topics at UNOS, management forums, online webinars, and ATC meetings. He has published many abstracts for which he has co-authored with national and international transplant colleagues. At the 2014 UNOS Management Forum, Alex received the prestigious Heckenkamper Leader in Transplant Administration Award for his distinguished leadership in transplant administration. Our second presenter is Jimmy Mendez, BBA. Jimmy has over over 35 years in experience in the healthcare field, which includes working for a national consulting firm, a large multi-hospital system, a Medicare audit contractor, Trailblazer Health Enterprises, which is a CMS fiscal intermediary. He has also worked for Christus Health as a senior reimbursement specialist. As a senior reimbursement and cost specialist with Goodry and East, his duties include providing cost report-related consultation services in the areas of cost report audits, organ acquisition audits, disproportionate share hospital or DSH services, appeals, cost report preparation, and medical education reviews to include an assessment of bed management. And at this point, it is my pleasure to introduce and turn the program over to Alex.
Thank you, Belinda. Good afternoon, everyone. I would like to start by thanking the Alliance and Paragonix for allowing us to be part of this forum, and thank you to all attendees as well. Our topic today is going to be on the transplant cost report, our favorite topic, the vehicle to report organ acquisition services. A few disclosures before we go any further. Goodry and East, as we heard, provides professional consulting services on clinical, administrative, and transplant cost reporting to a large number of transplant hospitals, OPOs, and emerging technology companies in the United States and abroad. Goodry and East assists companies to bring new FDA, CMS, and CLIA-approved technologies to market. And we do have a retainer contract with Paragonix, the sponsor of today's forum. Learning objectives from today's presentation. We discussed it with Jimmy, and I think the top 5 learning objectives from today are going to be, for all of us to identify the universal phases of transplant and how do these phases of transplant relate to organ acquisition services. And we're going to be defining organ acquisition services in more detail. We're going to talk about organ perfusion and preservation services as part of organ acquisition costs and all the rules and regs behind that. Jimmy is going to take over to describe the transplant cost report, the mechanics of the cost report, the CMS cost reimbursement, and some best practices. And then we'll summarize how Medicare reconciles annual acquisition service costs with transplant hospitals. So to start with, defining or identifying the universal phases of transplant, these are by and large 4 distinct phases. Phase 1 is when an initial patient is referred to your program and is subjected to a protocol-based evaluation. At the end of that evaluation, the patient ends up being added to the waiting list, being declined as a candidate, or being deferred for additional testing. So they remain in this phase until they're added to the waiting list. Once they get accepted and added to the waiting list, then we move into phase 2. Unfortunately, we don't have organs on a printer yet, but hopefully, in the future we may have on-demand organs available, but until then, patients have to wait on waiting lists. So they wait on a waiting list for organ, and they continue to be seen by the transplant program for an extended period of time, sometimes dependent on organ type and disease, so that they can continue to be maintained as a appropriate candidate for transplantation. So that phase 2 is when the patient is added to the waiting list and includes the maintenance phase. Now, when they get that call that an organ is available for them, the patient ends up being admitted to the hospital for the actual transplant procedure and subsequent inpatient stay until the first discharge. That's what we call phase 3. And phase 4 is the post-transplant care after the patient is discharged from the hospital and any follow-up that follows long-term in the future. So what are organ acquisition costs? These are generally all type of costs that represent, the attempt of the hospital to acquire the organ any type of cost, both hospital costs and professional fees, to prepare the potential donor and or to prepare the recipient for organ transplantation. So I know that's a big statement, but we're going to go into more details as we dive below the 5,000-foot level here in our definition. What's important there is to mention that organ acquisition costs are applicable to both Medicare and non-Medicare patients. And they're reimbursable by Medicare under the Code of Federal Regulation 42, Section 412.100B. So now if we take a deeper dive into the details of what organ acquisition costs are, here we look at all the tissue typing and cross-match services, including those furnished by independent laboratories, provided that UNOS have blessed, has approved them to provide the service. Live donor recipient evaluations, any operating room and other inpatient ancillary services applicable to the donor. Any costs associated with excising organs, such as donor routine and special care services. Those charges to register the patient with the UNOS registry, and not any other registry if it's a duplicative effort that UNOS provides. Any medical directorship costs, primarily those non-billable administrative time that physicians really put in to manage a program. Any preservation and perfusion costs, and for perfusion it includes obviously pulse perfusion costs, and for preservation it's the static preservation of organs, moving them and transporting them from point A to point B. Any surgeon fees to excise the deceased donor organ, the transport of organ from and to the transplant hospital, and any costs for organs acquired from other OPOs, and we call those imports, and all diagnostic interpretations of pre-transplant physician professional services. These include any type of pre-transplant physician interpretations for lab, pathology, X-ray, or other tests. Now, talking a little bit about preservation and perfusion costs, obviously the ideal preservation method for organs during any ischemia, both warm or cold ischemia, must maximize the quality of the organ, minimize the chance of delayed graft function, DGF, and maintain organ viability for transplant. So all preservation and perfusion costs are considered pass-through costs since 1978. And the rule there is reflected in the section that we identified early as organ acquisition under Section 412.100, and it was initially applicable for kidney transplant centers. However, many revisions followed that, revised in 87, 92, 03, and most recently in 2016 in the Medicare Provider Manual. That's Chapter 31, Part 1, and it talks about organ acquisition payment policy. So what you see there is the actual extract from Chapter 31, right there is Transmittal 471, and you can see in one of the bullets, bullet number 5, preservation and perfusion costs is clearly identified as an acquisition cost that is going to be passed through the standard acquisition charge, among others. So now, we've been talking about patient-related costs, those patients that are going through the pre-transplant evaluation process and during the maintenance period. And now we need to add to those additional direct and indirect costs of operating the transplant program. So included also in organ acquisition, we have direct costs of the transplant department personnel, those that are out there doing outreach and education, any costs related to travel and meeting expenses for those personnel, professional education, office rent, office supplies, equipment maintenance, professional subscriptions, you name it, anything that has to do with operating a transplant program. And then on top of that, you've got obviously the indirect cost, which is an additional cost added to direct for non-revenue producing departments. And that includes depreciation and interest, plant operations, housekeeping, social services, any other non-revenue producing department within the hospital. So basically, these are the cost centers normally reflected on worksheet B1 of your cost report, hospital cost report. Now, there are some costs that are absolutely non-allowable to be added to the cost report when you file CMS. These are travel, room, and board expenses incurred by a live donor. The same if incurred by a recipient. Transport of the potential deceased donor to the transplant hospital. As I said, only the organ is allowable. Any duplicative expenses, including those paid to National Kidney Registry or similar vendors for services that UNOS already provides. Any burial expenses of the deceased donor, and payments made when the next of kin or live donor sells the organ. In fact, now we are required as transplant programs to consent the patient and the live donor that on the fact that buying or selling organs in the United States is illegal. So organ acquisition services are basically those services provided, as we said, to prepare the recipient and the donor for the actual transplant. So it gives you the hint that anything done on the pre-transplant side is a potential candidate for it being an organ acquisition cost. So in order to fully understand the concept of pre-transplant versus post-transplant, it's helpful to link those services to the phases of the universal transplant process. As such, you can see that for a recipient, normally organ acquisition is acquired in phases 1 and 2. Phase 3, inpatient stay, is usually an MSDRG if it's a Medicare case, or it's a contracted rate if it's a non-Medicare case, commercial payer case. For phase 4, post-transplant and long-term post-transplant, you're looking at APCs for outpatient payments. If the patient ends up being readmitted to the hospital, it will be an MSDRG and or a contracted rate for commercial payers. So for a donor, organ acquisition services are a little bit more comprehensive. They include phase 1, phase 2, and phase 3. So similar to recipients, but phase 3 here, where the inpatient stay for organ donation is also considered organ acquisition. And during phase 4, organ acquisition is reflected up to 6 months following the discharge date. So that's post-transplant of the recipient, basically, after organ removal for about 6 months. Any complications, though, from the organ donation itself must be billed to the recipient's insurance, including Medicare. And for Medicare patients, it is for an unlimited number of days. Even if the recipient ends up dying and the donor develops complication, as long as these complications are related to the donation process and it's documented as such in the medical record, you can continue to bill Medicare for an unlimited number of days for that complication. Now, we all know and understand that that may not be the case for some insurance plans, and this is what your contract management department needs to be on top of it to ensure the well-being of the live donor as part of the contractual agreement with commercial payers. So again, for the visual folks amongst you, like I am, one more time, pre-transplant evaluation for recipients is phases 1 and 2. That's what we consider organ acquisition. For live donors, it's all phases. However, donor complications after the first discharge are billed to the recipient's insurance, including Medicare. And organ acquisition for the donor is normally for up to 6 months after discharge. So the organ acquisition bucket here includes, as we said, direct costs, routine ancillary costs, and hospital overhead. So how do commercial payers reimburse hospitals for transplant services? So generally speaking, a negotiated rate as a percent of charges for outpatient pre-transplant services in phases 1 and 2 is the most common contractual agreement that we see out there from our expanded travels. An MSDRG model payment or a model payment based on MSDRGs with a negotiated rate for the transplant event and related inpatient stay, and that could extend to like 45 days, 60 days, 90 days, or sometimes we've seen it as out there 120 days after the first discharge. That's all part of the same case rate that commercial payers pay. Again, after that, for phase 4, it reverts back to percent of charges that are negotiated for outpatient post-transplant services. Again, this is all payer dependent and hospital dependent as well. It depends on your contracting team and their ability to make sure that the benefit of the recipient and donor are well preserved in their contractual agreement with commercial payers. Now, Medicare reimbursement method is a bit different. Obviously, the MSDRG, prospective payment system for the transplant event and related inpatient stay. The APCs, this is part, again, of the prospective payment system for outpatient post-transplant services. However, for pre-transplant services, the Medicare program is not billed. Those organ acquisition costs on primary Medicare patients are reimbursed through the Medicare cost report for those CMS certified centers. So obviously, transplant centers must be certified by CMS to be eligible for organ acquisition reimbursement. In addition, they must be members of the OPTN, the Organ Procurement Transplant Network. It's a division of the U.S. Department of Health and Human Services. CMS relies partially on UNOS for notification of program noncompliance with volume and quality outcomes. But UNOS is the contractor for the OPTN. And UNOS is involved in many aspects of the organ transplant donation process. And that includes managing the national waiting list, matching donors to recipients, maintaining the database that contains all organ transplant data for every transplant event that occurs in the U.S., and monitoring every organ match to ensure the organ allocation policies are being upheld and followed by transplant programs and OPOs. So hospitals and certified transplant centers are eligible to receive pass-through reimbursement on a cost basis from Medicare for organ acquisition costs for the Medicare share of that cost. So the question here is, does Medicare pay 100% of these acquisition costs? And the answer is no. They only pay their share of the cost. So that's a payment determined by the Medicare cost report, which Jimmy is going to go over the detail of that, mechanics of it. It's a payment outside of the prospective payment system, the PPS system that we talked about. So it will be in addition to what you would be receiving for phase 3, phase 4 from Medicare. There are approximately 250 hospitals in the U.S. certified to transplant one or more organs, 150 HLA labs and OPOs. They all file cost reports, and their cost reporting methodology is kind of similar with some key differences. They're typically your larger hospitals, particularly those affiliated with academic institutions. And the most common transplanted organs are kidney, heart, liver, and lungs. Now, effective 10/1/2020, bone marrow transplant is going to follow reimbursement guidelines for organ acquisition. Now, we're saying this, we feel comfortable saying this because it's now reflected in regulation, part of the CARES Act, but we have not seen any type of cost support instructions of how they're going to implement that. So I'm hoping that Jimmy could also comment on it as part of his presentation here in a bit. And effective January 2021, the Medicare Advantage plans would follow reimbursement guidelines for organ acquisition. So, we know that those Medicare Advantage transplants are going to be counted as Medicare organs, but as far as the vehicle for organ acquisition, how it's going to be paid, and whether they should follow 100% the current Medicare guidelines, we have not seen yet any cost reporting instructions that provides that level of detail. So without any further ado, I would like to turn over the forum to Jimmy right now so that he can walk us through the transplant cost report and best practices. Jimmy?
Thank you, Alex. Well, as you all know, the vehicle that CMS uses to determine their share of organ acquisition costs is the Medicare cost report. Now, the Medicare cost report, essentially what happens is CMS, via Medicare, they make interim payments throughout the year to hospitals. And at the end of the year, annually, a Medicare cost report is filed, and it determines whether the hospital was overpaid in the interim or underpaid in the interim, and a settlement occurs. So let's talk about the cost report itself. There are certain pertinent worksheets that are very important to organ acquisition, and they're displayed on this slide. Worksheet A essentially is a reflection of your general ledger. It's the direct costs that were booked to your general ledger. Worksheet A6 is a mechanism of the cost report that allows you to reclassify costs from one Medicare cost report cost center to another. Worksheet A8 is where you can make adjustments to expenses. Earlier, Alex talked about some non-allowable expenses. Well, this is where you would remove the costs from organ acquisition reimbursable costs through Worksheet A8. Worksheet A8-1 is where related party expenses are reported. The hospital will report what's on their general ledger, and it compares to the actual cost of the related party, and the difference is adjusted into the cost report. Worksheet AA2 is where physician compensation and related hours are documented. Worksheet B-1 contains the overhead statistics that are used to allocate costs from non-revenue producing cost centers to revenue producing cost centers, of which organ acquisition is one. And finally, Worksheet D-4, this is where the ultimate Medicare settlement is determined. So we're going to focus on hospital cost reports and Worksheet A and Worksheet D-4, and touch a little bit on A6. So basically, an important component of the direct costs that is populated on Worksheet A are the salaries. And salaries for organ acquisition reimbursement need to be categorized as either pre-transplant or post-transplant, and sometimes possibly non-transplant time. And the mechanism to establish how to classify these salaries are time studies. Now, this is an area where many hospital transplant centers have difficulty, and so I'd like to go over the time study requirements. A minimally acceptable time study must encompass at least one full week per month of the cost reporting period. So in the end, you'll wind up with 12 one-week time studies. Each week selected must be a full work week. The week selected must be equally distributed among the months in the cost reporting period. So at the end of the year, the goal is for the first week of the month to be documented in 25% of your time studies, the second week of the month to be documented in 25% of your time studies, and so forth for the third and fourth week of the month. So there'll be evenly spread representation of the work that is conducted in a normal month. Now, having said that, no two consecutive months may use the same week for the study. So if the second week beginning in April is the study week for April, the week selected for March and May shall not be the second week beginning in those months. In addition, a time study must be contemporaneous with the cost to be allocated. The time records to be maintained must be specified in a written plan submitted to your MAC no later than 90 days prior to the end of the cost reporting period to which the plan is to apply. So we just discussed the salaries, which is a big component of your direct costs. Now let's discuss the non-salary costs, or the other costs that has been booked to your general ledger and ultimately wound up on worksheet A of the cost report. So the best practice would be to create GL accounts for pre-transplant costs only. This would be costs such as the purchasing of the organs from the OPO, HLA lab fees, organ perfusion and preservation, organ transplantation, evaluation services provided by outsiders, outreach expenses, and so forth. And group these, expense them to an account that's specific to pre-transplant, and then group that account in the organ acquisition cost center of worksheet A. You could do the same thing for post-transplant. You create a GL account inclusive of only post-transplant, such as HLA antibody class 1 and 2 tests, or HLA tests performed on a recipient that is after the transplant date. That would also be post-transplant, and this is the type of expense that could be captured in a separately identified post-transplant account and then mapped to your post-transplant cost center on worksheet A. So we just discussed costs that we can identify specifically as pre or specifically as post. But what about the other costs that benefits a department, the transplant department in general, such as office supplies, professional education, delivery fees, communication fees, and so forth? If you can book these accounts separately, then at some point they need to be allocated to either the organ acquisition or pre-transplant cost center or the post-transplant cost center. And what you would do is you would utilize worksheet A6 to move the cost to a cost center that it belongs to. So if it has originally been booked in an account that is grouped with organ acquisition, you would leave in there the pre-transplant portion, but you would reclassify out the post-transplant portion or the non-transplant portion. An example of doing this is to utilize the overall pre versus post percentage of the employees in the specific department where the costs are being allocated, and use that to move the costs. So we've just discussed the costs that are booked to your general ledger as expense and therefore make their way to worksheet A of the cost report. But what about the cost to a hospital when they are treating and providing services to a pre-transplant patient in their own facility? How is cost derived and ultimately reimbursed? Well, first of all, evaluation services provided to potential living donors and potential transplant candidates, living donors during the stay related to the donation, and patients who expired at the hospital and whose organs were excised at the hospital and procured by the Organ Procurement Organization. Those services provided to this group of patients would be captured, compiled, and through the cost report, ultimately, cost is determined and reimbursed. And we'll go over that in a minute. So the charges and days related to the patients are reported on worksheet D-4, Part 1. The hospital's ancillary charges are converted to costs using cost-to-charge ratios from worksheet C, and the routine days are multiplied by cost per diems established on worksheet D-1 to develop the routine costs. So essentially, the cost report itself will provide cost-to-charge ratios that can be utilized and provide per diems by nursing floor units, and these can be applied to the compilation of charges and days that have been identified for servicing the patients that were described in the previous slide. Now, I'd like to note that hospitals should not be billing Medicare for these pre-transplant services on Medicare patients, but rather claiming them on the Medicare cost report on worksheet D-4. Billing Medicare creates a potential compliance issue. Now, the exception to this is the recently released regulations regarding BMT. For those, Medicare actually wants you to bill Medicare for the evaluation services, but they want you to hold on to the charges up until the transplant occurs, and then you're allowed to bill at that point. Again, as Alex mentioned, the mechanism of how the cost report is going to be used to absorb these new regulations is not fully clear at this point. So when a hospital is providing services to a recipient, how should they be handled? Well, for phase 1 and 2, phase 1 being the referral and evaluation phase 2 being the maintenance while you're on the wait list. For a Medicare recipient, you would want to write off the charges and capture the charges on the cost report, and ultimately you reimburse through the cost report. For a non-Medicare recipient, you're going to want to bill the payer according to your contract, but you also capture the charges for the cost report. Now, on the surface, this appears to be a double dipping, but later you will see how Medicare ultimately only pays their share of the cost. For phase 3, the transplant event, for Medicare, as Alex discussed earlier, you're going to bill the MAC and you'll be reimbursed via the prospective payment system. For non-Medicare, you bill your payer according to contract. For post-transplant, again, for a Medicare recipient, you bill the MAC, you're reimbursed on the prospective payment system, and then for non-Medicare, you'll bill your payer according to your contract. For the donor, it varies in a few areas, in a few of the phases. First of all, for a donor, a live donor who is donating to a Medicare recipient, for phases 1 and 2, you write off the charges and you capture them on the cost report. The same is true for a live donor donating to a non-Medicare recipient. For phase 3, however, for the Medicare recipient, for a Medicare live donor to a Medicare recipient, you would write off the charges and capture the charges and days on the cost report. Earlier you saw where for the recipient that is Medicare, you would bill and get paid on an MSDRG basis. So that's a difference here. For a non-Medicare recipient, again, you would write off the charges and capture the charges on the cost report. Now, ultimately, a hospital will be reimbursed for the donors, reimbursed via the SAC, and this is from the recipient's insurer. For post-transplant, write off the charges and capture the charges on the cost report for both Medicare recipient of a live donor and non-Medicare recipient of a live donor up to 6 months following the discharge. However, if it is related to complications of the donation event, then the Medicare recipient's insurer would be billed. So what Medicare does is they ultimately, to determine their share of the cost, they ultimately apply a Medicare ratio. So Medicare only pays for their share of the organ acquisition cost by applying this ratio. And that earlier when I mentioned that we were capturing the charges that are related to non-Medicare, the reason you do that is because of the Medicare ratio application. If your bucket isn't full and comprised of both Medicare and non-Medicare, and then you apply a Medicare ratio, well, you'll be shortchanging yourself. So it needs to include both Medicare and non-Medicare. And the Medicare ratio is simply Medicare usable organs divided by total usable organs. A Medicare usable organ is an organ transplanted at the hospital where Medicare was the primary insurer. Deceased donor organs recovered at the hospital with intent to transplant and procured by an OPO or sent to another transplant center. And under certain circumstances, organs that were transplanted where Medicare was secondarily liable on the recipient's account. Only traditional Medicare organs are included in the numerator of the Medicare ratio. Managed care Medicare or Medicare Part C organs are only included in the denominator of the Medicare ratio. However, effective on January 21st, managed care Medicare organs will be treated as traditional Medicare for cost reporting purposes, hence included in the numerator and denominator of the Medicare ratio. So that's your numerator. The denominator is your total usable organs. And what are those? Well, that's organs transplanted at the hospital from any insurance type, plus deceased donors donor organs recovered at the hospital with the intent to transplant and procured by an OPO or sent to another transplant center. Now, earlier we said that under certain circumstances where Medicare is secondarily liable, you may be able to count a Medicare organ as part of the Medicare ratio. Well, in order for an MSP to qualify as a Medicare organ, it must meet 3 requirements. Medicare must have been billed. There is a remaining liability from Medicare after the primary payer's payment is received. And the contractual language of payers should not have any payment in full language. Now, it must beat all 3 before you can count an organ where Medicare is secondarily liable as a Medicare organ on the Medicare ratio. The second dash, to define Medicare's liability, you would need to add Medicare's liability in regards to the fully loaded MSDRG plus the organ acquisition cost per organ derived from your cost report. So you add those 2 together and they jointly define Medicare's liability. If the primary payer's payment is less than that and therefore there is a outstanding Medicare liability, that is when you are allowed to count that organ as a Medicare organ, but it would also go in your denominator as well. Now, we'd like to note that there is a corresponding offset equal to the organ acquisition portion of the payment receipt. So once you've established your organ acquisition costs and you've applied the Medicare ratio and you've arrived at your Medicare share of organ acquisition costs, there's also a revenue offset that needs to occur. And this pertains to revenues derived from organs sold to organ procurement organizations or other certified transplant centers. It must be offset against Medicare's share of organ acquisition costs. Now, these other certified transplant centers, that would be, for example, a kidney pair donation, and where a live donor at your facility's organ was shipped out to another transplant center, and that transplant center paid you for that payment needs to be offset. If the OPO pays the hospital a total amount per deceased donor, the hospital should prorate the payment received over all organs to include non-certified organs. There are some OPOs out there that will actually apply or have a distinct payment for each individual organ identified. Therefore, a proration in that situation would not be necessary. So here's just an example, a simple example of how the cost report is summarized and how Medicare ultimately determines their share. First of all, there's the direct cost portion, the organ acquisition cost. Direct cost is, like we said earlier, it's a reflection, it's from worksheet A, a reflection of general ledger, plus or minus worksheet A6 reclassification. So for example, the salaries that were moved out to the post-transplant cost center would be used to reduce the number that originated initially on worksheet A, and also plus or minus any adjustments such as removal of non-allowable costs or the offsetting of miscellaneous income. To the direct costs, you would add the indirect costs, which essentially is the cost for all your non-revenue producing cost centers being allocated to your revenue producing cost centers utilizing statistical allocation bases that are found on worksheet B-1. The dollars related to the worksheet B-1 allocations are found on worksheet B part 1. To that, you would add the cost derived from organ acquisition charges and days. This is when you compile charges that you've written off, but you compile them for the cost report because they were for services provided to pre-transplant situations, and they are converted to cost by the utilization of cost-to-charge ratios and per diems. So in our example, the total organ acquisition cost is $8.3 million. Now comes the Medicare ratio. So in our example, we had 60 Medicare usable organs, 80 of them in total for a 75% Medicare ratio. In our example, that means that the total Medicare reimbursement or Medicare share of the reimbursement is $6.225 million. However, the OPO procured some organs, or we may have sent some kidney impaired donations, shipped them out, received payment. Those total to $425,000. So in our example, the net Medicare reimbursement is $5.8 million. So in summary, understanding what organ acquisition services are and the relationship to the universal phases of transplant is key to a successful cost reporting experience. Organ perfusion and preservation services are part of the organ acquisition costs generally paid for the transplant program as purchased services. The multiple components of a transplant cost report require close coordination between front-end staff, including administration for optimal CMS cost reimbursement. And of course, we all need to keep an eye on how Medicare reconciles acquisition service costs with transplant hospitals in view of the CARES Act changes. So here is our contact information. There's Alex on top and then me below that. I work for both Jimmy Guidry and East, but I am employed by Bester Consulting, and who has a contract with Guidry and East. And there is my contact information. Belinda, I'll send it back to you.
All right. Thank you so much, Alex and Jimmy. We really appreciate your time and for sharing such a fantastic presentation. To all of our participants, we're now going to go ahead and transition into our Q&A discussion. But just as a reminder for everyone, if you do have any questions for either presenter, please be sure to submit them using the chat feature. Just as a reminder, that's located on the bottom left-hand corner of your screen. And then additionally, during the Q&A session, I'll have this poll up. So for those of you who are participating in a group, if you could please just let us know how many people are participating in your respective group, we'd greatly appreciate that. That being said, I'll go ahead and turn it back to Belinda to facilitate the Q&A discussion. Thank you. All right, it sounds like we may have lost Belinda, so I will
Can you
go
hear
ahead
me?
and kick us off. Oh, there you are.
I'm sorry, I think I was muted. So our first question is from Cassie Jensen. Her question is, after accepting a deceased organ, our clinical teams will order certain lab tests on the organ for the care post-transplant, not to determine if we will use the organ. Can we bill these labs to the recipient?
Okay. I would say it depends on the type of test that you're running. I mean, if the test is being done on the organ while you are still in procurement mode, then it would be part of organ acquisition. And for commercial payer, you ultimately end up billing the recipient's insurance based on the contracted fee. But for a Medicare organ, that sits as an additional expense under your purchase services on the cost report. Now, again, it all depends on what the test is. So it would have helped if I had specific tests there that we could, we could have a better answer for you.
Thank you, Alex. Our next question is from William Sparks. Can you elaborate on the 6-month post-donation activity that can be claimed as acquisition and how that differs from the UNOS required follow-up that CMS indicates isn't billable to any payer?
Okay. Let me just clarify with Jimmy here. Jimmy, have you seen any regulation that says CMS indicates that that type of follow-up is not billable to any payer on live donors after the 6-month period? Because I haven't. So
I have not either.
Yeah. So within the initial 6-month period post-donation, any routine type of follow-up for the live donor is part of organ acquisition. However, after that period, it becomes more if the live donor is stable, it becomes more of general maintenance, which either the live donor would be paying for their annual follow-ups through their regular physician, and or some centers may have considered billing the recipients or recipients insurance for that. That said, I can tell you that most centers that we talk to are electing to continue to follow up on the live donors for the UNOS required period without any charge. But even then, I would recommend that you contact your compliance officer within the hospital to make sure that this practice is adequate.
Okay, so if I understand that correctly, you're saying so for the living donors for their 1 and 2 year follow-ups, how does that get reimbursed?
Yeah, so it's normally either through the live donor insurance or through the recipient's insurance, dependent on contractual agreement. And or what we're seeing is that hospitals are just not billing the live donor at all.
Okay, thank you. Our next question is from Benjamin Schleich. If we recalculate our SAC mid-year, can it be applied mid-year, or can it only be done once at the beginning of the year?
Jimmy?
I have not seen anything that says that you are not allowed to change it in mid-year. I suppose a lot of it would also depend on how your contractual language reads with your commercial payers.
Yeah. There is one state in the U.S., Maryland, that basically calculates their standard acquisition charge on a monthly basis. That's because the way they get reimbursed is a little bit different than the rest of the nation for Medicare and Medicaid cases.
Thank you. Our next one is from Richard Petrosky. How are charges for normothermic organ perfusion and any added transportation costs of organs? I'm sorry, I lost my place here. Split up. Such as livers, hearts, and lungs by an OPO center or independent perfusion lab handled on a Medicare cost report.
So this is OPO specific. Jimmy?
Yeah, I am not as well versed with OPO cost reports, so that is something that I cannot currently answer, but I can research that.
Thank you. Our next question is from Phyllis Weeks. For living donor nephrectomies of Medicare recipients, should the anesthesia services, a contracted group, be billed directly to recipients' Medicare insurance, or should the hospital pay and code for reimbursement?
Okay, so let me read it one more time.
Okay.
For live donor nephrectomies on Medicare recipients, should anesthesia services, it being a contracted group, be billed directly to recipients' Medicare insurance? So this is a live donor component. I mean, all the live donor services on Medicare patients are going to be part of a live donor standard acquisition charge that the hospital must have developed early on. So the short answer is that you do not bill anesthesia services on live donors to the Medicare system. You bill it to the hospital, and the hospital would have an agreement with you on reimbursement. Jimmy, correct me if I'm wrong.
No, I think that sounds right.
Okay, our next question is from Chara Chen. Does the CARES Act change mean that for Medicare Advantage plans, pre-transplant evaluation charges would be claimed on the cost report and not get billed out to payers?
That's on Medicare patients.
So essentially, that the treatment on the cost report after January 2021 will be the same for Medicare Part C as we are currently handling for traditional Medicare.
So that's on Medicare patients. But if you have a contract with commercial payers, that would be different. So, but I suspect that Medicare Advantage plan basically would be a straight Medicare case. So it'll be treated, as Jimmy said, as a straight Medicare.
All right, our next question is from Thera Rhodes. Our group is asking if commercial insurance should be billed for pre-transplant services.
Yes, the answer is yes. You should bill according to your contract, and the reason for that is because the question was, should we be billing? Yes, so you bill the commercial payer, but you also capture the charges for the cost report, so you do both.
Okay, our next question is from Eduardo Medina. Will there be any changes in living donor long-term complication coverage with the new Advantage Medicare plans?
Not to our knowledge. I mean, any complication.
Yeah, I'm not aware of anything.
Yeah. I mean, this particular rule is still evolving. Instructions are still pending. But to our knowledge, if they are to be considered part of the Medicare, the regular, Medicare fee-for-service application and how we treat them on the cost report, then any complication would continue to be billed to the Medicare program accordingly.
Thera Rhodes wants to know, how are the reporting requirements different for transplant with Medicare now adding bone marrow transplant?
Can you repeat that? I'm sorry?
Yes. How are the reporting requirements different for transplant with Medicare now adding bone marrow transplant?
Well, as Alex mentioned earlier, the mechanism of how the cost report will be used is not entirely clear yet. What we know is that BMT will now be reimbursed on a reasonable cost basis, and we know that there is a difference in that for solid organs, you do not bill Medicare for pre-transplant services. For BMT, the regulations state for you to compile and hold the charges, and when a transplant occurs, at that point you can bill Medicare for Medicare patients. So there's a slight deviation there. But as far as how the cost report will mechanically be used to calculate the reasonable cost, at this point I am not aware that has been fully determined. I have some questions that I've sent out to CMS that will help me fully understand that, but as of today I have not received a reply.
I see that we're close to the top of the hour. We have 8 more questions. So, Deanna, I need guidance on how we proceed.
Yeah, I would say thank you, everyone, for your questions. We have a couple minutes, so maybe 1 or 2 additional questions. But for those that are remaining in the queue, if Alex and Jimmy are okay with it, maybe we can follow up with everyone via email.
Sure.
All right, great.
All right, then we'll take one last question. It's from Krista Vian. If a pre-transplant evaluation is done as an inpatient evaluation due to patient condition, how much of the stay can be attributed to pre-transplant costs? Is it necessary to comb through all the daily charges to pull out specific charges, or can we denote the whole inpatient stay to pre-transplant? I've heard centers approaching this differently.
Yeah, absolutely, and we've seen a different approach as well from multiple centers. But we can tell you that anything that is being done as part of the pre-transplant evaluation on a diagnostic basis is considered organ acquisition. That means any type of diagnostic testing being done to qualify this patient and prepare the patient for presentation selection committee, this is organ acquisition. Centers, we see that they stick to that. And they do it only on a diagnostic basis. But we've got also other programs out there that mix both therapy with pre-transplant evaluation. At such time, you're going to need to comb through those charges, preferably on a daily basis, to pull out specific charges that do not belong there because they were therapies, and move those out from your log on the cost report.
Thank you so much for your responses to all of these questions. As Deanna mentioned previously, we are at the top of the hour. We have about 7 questions left. If you would be so kind as to respond to those, and we can make sure that the posers of the questions get your responses. At this point, I will turn the program back over to Deanna.
Thank you so much, Belinda. Yes, and I just want to reiterate for everyone, I did see a question come in regarding the presentation deck. For those of you who are curious to know whether or not those will be shared, we will be sure to send that out to everyone via email following the conclusion of today's webinar, so just be on the lookout for that. And as Belinda mentioned, we will ask Alex and Jimmy to address some of the remaining questions here. So for those of you who may have any last-minute questions that you'd like submitted and addressed, you can go ahead and continue to type them into the chat, and we will, again, follow up with you via email. But that said, I'd like to go ahead and officially conclude the Q&A discussion. And on behalf of the Alliance, I want to extend my sincerest thanks to Alex and Jimmy for such a fantastic and I think highly informative presentation. As you can see by the level of engagement that we've had here today, this has been a topic of high interest within the community. So I really appreciate you both for taking the time to join us and to share your insights. And additionally, Belinda, thank you for doing such a fantastic job, as always, facilitating our Q&A discussion and moderating today's program. So thank you to all 3 of you. I really appreciate your time and your efforts. And to all of our participants, as always, we thank you for joining us, and we hope you found this presentation to be highly valuable. And we hope to see you again in the future. Enjoy the rest of your day, everyone.